Now I will talk on flexor tendon injuries and repairs. Flexor tendon injuries are a traumatic condition classified by the zone of injury. Understanding about the zone and pulley system is very important in flexor tendon injuries. Location of the laceration directly affects the healing potential. It commonly results from the volar laceration, and patients may have a associated neurovascular injury. Tendon healing occurs via two pathways, intrinsic and extrinsic. Intrinsic is produced by the tenocytes within the tendon. Extrinsic is stimulated by surrounding synovial fluid and inflammatory cells implicated in the formation of scarring and adhesions. Coming to the pulley system. Digits 1 to 4 contain 5 annular pulleys A1 to A5. A2 and A4 arise from periosteum. A1, A3 and A5 arise from the volar plate. Odd pulleys arise from the volar plate. Most important pulleys to prevent flexor tendon bowstringing. 3 cruciate pulleys C1 to C3 are collapsible and flexible, allows the annular pulleys to approximate each other during digital flexion. Thumb contains 2 pulleys, 2 annular pulleys and 1 interposed oblique pulleys, totally 3 pulleys. Classification of tendon injuries. It applies to the 4 fingers except thumb. Zone 1 distal to the FDS insertion. Zone 2 FDS insertion to distal palmar crease. Proximal A1 pulley. Zone 3 palm A1 pulley to distal aspect of carpal ligament. Zone 4 carpal tunnel. Zone 5 carpal tunnel to forearm. Coming to the treatment. Non-operative treatment is rarely indicated in flexor tendon injuries. If there is a partial laceration, less than 60% of the tendon width is damaged, in such cases you can treat it non-operatively. Otherwise, operative treatment is indicated. Flexor tendon repair you have to perform within 3 weeks of the injury. Ideally is as early as possible, at least less than 2 weeks. You can do under proper anesthesia or wide awake. Flexor tendon repair can be done under local anesthesia. In neglected cases, you have to do flexor tendon reconstruction. Complications after flexor tendon repair. Flexor tendon injuries continue to challenge surgeons and their patients who seek a full return of finger function after repairs. Zone 2 flexor tendon injuries between the proximal edge of the flexor digitorum tendon sheath and flexor digitorum superficial insertions on the middle phalanx require the most technically precise repairs and dedicated rehabilitation to achieve satisfactory outcomes. These repairs continue to be complicated by adhesions that limit active finger range of motion and that lead to substantial rates of post-operative ruptures. A meta-analysis documented 6% rate of reoperation, 4% rate of rupture, 4% rate of adhesions after flexor tendon repair, almost 14 to 15% complication rate. Unfortunately, the incidence of complications has not been decreased since 2000. The effect of gap formation at the repair site on the strength and excrusion. Flexor tendon repairs begin to accrue strength at 3 weeks. A gap at the repair site of more than 3 mm does not increase the prevalence of adhesions or impair the range of motion, but does prevent the accrual strength and stiffness that normally occurs with the time. They will have less strength and less stiffness if there is a gap. There are different types of tendon repair techniques are there, 2 strand, 4 strand, but not a single suture configuration or a type of suture has a proven superior. But modern multi-strand technique with at least 7 to 10 millimeter of core suture purchase and 10% of the tightening at the repair site minimizes the gap formation. The ultimate strength were not significantly different among the tendons with either 2 strand or a 4 strand repair of any degree shortening. Main important is it should hold the tendon ends and there should not be any gap between the cut ends. The purchase and tension of the core suture and the direction and curvature of the path of the tendon motion have been found to be determining factors in the results of tendon repair. Active motion rehabilitation requires a minimum of 4 core suture strands across the repair site. You have to put at least 4 core sutures if you want to actively mobilize the hand. Wide awake flexor tendon repair. Performing a flexor tendon repairs under wide awake local anesthesia offers the advantage of allowing the surgeon to visualize any gapping at the repair site or impeded excursion during active motion in the operating room. Total active movement examination of the freshly repaired flexor tendons has permitted the intraoperative observation of tendon repair gapping induced by active movement when the core suture is tied too loosely. The gap can be repaired intraoperatively to decrease the post-operative tendon repair rupture rates. Technical and biological modifications for enhanced flexor tendon repair. The need to achieve early tendon excursion to limit adhesion formation while preserving the integrity of repairs has prompted recent research into optimizing repair strength, early healing, and rehabilitation. Laboratory investigations have examined growth factor modulation in an attempt to speed tendon healing, but these efforts have yet to translate into clinical practice. Active compared with the passive motion therapy in auto tendon repair. At all time points, patients treated with the active motion program had a greater interphalangeal joint motion. The active motion group had both significantly smaller flexion contractures and a greater satisfaction scores. Active motion therapy provides a greater active finger motion than passive motion therapy after zone 2 flexor tendon repair without increasing the risk of tendon rupture. Ideally, repair it properly and start active movements as early as possible. Coming to the complications. Tendon adhesions, re-rupture, joint contractures, swan neck deformity, trigger finger are common complications. Some patients may have lumbrical plus finger, that is paradoxical extension of the IP joints while attempting to flex the fingers. Quadrisia, that is active flexion lag in fingers adjacent to digit with a previously injured or repaired flexor digitorum profundus tendon. These are some of the complications of flexor tendon injuries and repair.